anything else, it's the medical community, which is what this show is, showing people that we are adhering to social distancing rules and masks.
Get your contact info for the telephone numbers back here.
Yes, that would be great. Is there a telephone number that you'd like to put out to the audience?
Yep.
For the office?
Yep.
915
Uh-huh.
577
Uh-huh.
9339.
9339. And so the I have a website here, aao.org, which is the American Academy of Ophthalmology. That was on your slides.
No, that's not my website.
Right, that's for general information ophthalmology. Do you have a website that you'd like us to?
Yes.
Okay.
Children's Eye Center
Okay.
of El Paso, all together.
No.
No?
Children'sEyeCenter.com.
Oh, okay.
Children.
As far as the correct information website for children, it's not really AAO. It would be APOS.
Yeah,
AAPOS.
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 The American Academy of Pediatric Ophthalmology.
Okay.
.org.
Yeah.
Correct, yes, sir, .org.
Yes. Catherine, can you repeat that information just so
Absolutely,
control
yes.
can hear you?
So the website would be AAP as in pediatric, OS.org. And people would know that is the American Academy of Pediatric Ophthalmology.org. I'm just saying it slow for the guys in the back. And then the El Paso website would be children'seyecenter.com. And then the phone number is 915-9339.
No, 915-577-9339.
My apologies. So the number, my apologies, the phone number is 577
9339.
9339.
Yeah.
You get that, Gina? Okay, thank you.
Yeah? Okay. Allie? Which one's Allie?
6 minutes.
Say your last name for me. Kalafi. Kalafi. And then we have Sean. Is it Bala?
Yeah.
Thank you, Sean. Thank you for Allie for both being here.
Thank you for having us.
First year, second year, third years?
First years.
Both of you guys. Nice. Did you just move to El Paso?
Yes, ma'am. Recently.
5 minutes.
We're a lot friendlier without masks on. Give us a year.
Can we get them
We're
your phone
good.
number, please?
Yes, phone number is 881-0013. Oh, my phone number,
Your
duh.
phone. Yes, yes, yes.
Goodness gracious, my cell number, 471-0781.
So they can get you the question.
Exactly, my apologies. I'm
No,
still
no,
not
no
used to
worries.
that. I'm like,
Is it the first one? Is the area code 915?
yes, it is.
Okay.
915, and again, 471-0781. Throw in there Catherine Berg, so when I do call you on that night when I have an accident, you won't think I'm a junk call.
What is your name and your last
Catherine.
name? And your last
Berg,
name?
B-E-R-G.
Okay.
Like iceberg, but you can call me Catherine. We try to make this as casual as possible
Yeah.
because there's so many people that will click it off if it's like, you know, too medical or too, so we try to just have a nice conversation, pretend like we're at your favorite coffee shop, having coffee.
That is what I needed, a cup of coffee before I came. I was thinking to what?
You know what, I did, and I feel jittery, and I shouldn't have, because I had Zoom meetings all day long, and it was just like, oh, another screen, thank you. So I don't know if you remember how we do this, but the way that we do it is they'll give a countdown saying on, and then it's all quiet in the studio, and what's happening in the background is they're giving a disclaimer, so you guys can't get sued if you say something accidentally wrong.
Okay.
And then it will come back to us, I'll do the opening of the show, and then it'll be quiet again, because they're doing the opening of the show, and then from there, I introduce both of you officially, and then I ask you what you do all day every day, and ask you what you do all day every day.
Okay.
So a lot of the med questions obviously are going to go to you, and then maybe like procedural questions when somebody first calls the office, you know, how does that happen with nurse practitioners, et cetera.
Okay.
So so you know what I'm saying in the beginning, 1 out of 4 children have vision problems, yet most of these problems are not discovered until what should you look for? Maybe they are squinting a lot, maybe they bump into things more often than you think they should, maybe they are tilting their head in a certain direction when trying to look at something. During this next hour of experts answering questions about pediatric ophthalmology, we will talk about diagnosis, corrective measures, risk factors, and some treatments. As you know, this is a live program, so stay with us and think of some questions of your own you want to ask this evening. Call us at 881-0013. And again, I have to apologize for screwing that number up last time. Dear God, that was embarrassing. This evening's program is underwritten by the Children's Eye Center of El Paso and Children's Optical of El Paso. We also want to thank the Texas Tech Paulo Foster School of Medicine, and that's when you guys scratch your underarms and pick your nose.
Look at the camera, not the TV.
Thank you for telling me that. God bless you.
Catherine,
Yes.
be right here.
Okay, thank you. And you know what? It's Zoom meeting because I'm always looking into the Zoom meeting stuff. So yes, thank you very much. We also want to thank Texas Tech Paulo Foster School of Medicine for providing the medical students for you and the El Paso County Medical
Sorry,
Society.
these are the slides, so you just point out 1, 2, 3, whichever.
Okay,
Like,
so we're going to, because the type is so small, when we talk about the slides, we'll just have to talk about the pictures because people are not going to be able to read any of this on there.
Okay.
So,
So
Do you want-
you have
I'll give you a
slides
copy.
there, or I have the brochures here where they can
the
look
slide,
straight.
whoops, the slides will be, they have them in the studio. So
But
they're
then
going
I don't
to,
need these ones.
you don't need those, no, because the camera won't be able to pick those up.
Okay, perfect. Then I can just put them away.
You can sit on them.
Oh,
That's what I do when I have to put something away. I just sit on it. It's like,
this is a good idea.
this
Oh,
earring
so cool.
feels good, right?
It's good.
It was only 99 today.
Oh
Didn't
my
even hit
God.
100.
And then I had this jacket and I was in the car going, I'm not fixing it, can I get my jacket? No, leave it alone. Leave it alone. Yeah. And like, oh my gosh, I sit in this thing too. I can sit in the little.
1 minute.
I'm going to put this on my blouse because this is not working.
And it's okay, these two things here, because we may talk about
Yes,
this.
in fact, I want them there.
All right.
Who's got chills?
Haven't been here in 2 months.
Do you have COVID?
No.
Okay, just checking.
No.
No pressure.
30 seconds.
Okay. And we do try. I do that too. I'm like,
Stand by. 15. 9, 8, 7, 6, 5, 4, 3, 2, 1.
Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
1 out of 4 children have vision problems, yet most of these problems are not discovered in a timely manner. What should you look for? Maybe they are squinting a lot. Maybe they bump into things more than you think they should be, and maybe they are tilting their head in a certain direction when they're trying to look at something up close. During this next hour, we have experts answering questions about pediatric ophthalmology. We will talk about diagnosis, corrective measures, risk factors, and treatments. As you know, this is a live program, so stay with us and think some questions of your own that you want to call us and ask us this evening. The number is 881-0013. This evening's program is underwritten by the Children's Eye Center of El Paso and also the Children's Optical Center of El Paso. We want to thank the Texas Tech Paulo Foster School of Medicine for the medical students, 2 first years that are with us today, that are manning our phones, and also the El Paso County Medical Society for bringing this program to you. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Again, this is Catherine, and you are watching the El Paso Physician. We are going to talk about pediatric ophthalmology this evening. And again, the 2 students that we have with you, I always like to introduce the students to you at the beginning of the show because they're the ones that are answering the phones and taking your questions, and they're going to be texting the questions our way. No more handing of the calls because of social distancing. But our 2 students are Ali Kalafi and also Sean Bala. So guys, if you can wave at the cameras and say hello to everybody at home, and these are the 2 young men that are going to be helping us out this evening. Also, I wanted to kind of talk again about the doctors, but you really specialize in pediatric medicine, and this is Dr. Violeta Radenovich, correct?
Yes.
And you are a U.S. residency and fellowship trained pediatric ophthalmologist. You specialize and the diagnosis, which is so very important in young ages. You specialize in diagnosing and treating eye diseases and other issues. So welcome, and thank you for being here. And then also with us is Gabriela Avilos. Olivas, I have it misspelled here, who is our nurse practitioner, who also works in Dr. Radanovich's office. And Dr. Radanovich, if you can explain to the audience, so what I usually do with these shows, we call them the eyeball shows, there are optometrists and there are ophthalmologists. So let's first take that as the difference, and then let's go further into what you specialize in with pediatric ophthalmology. So talk about the difference between an optometrist and an ophthalmologist.
Well, an ophthalmologist is a medical doctor that did training and went to medical school, and normally it's 8 years of training, and then he did residency training, another specialization that is 4 years more, and the specialization in ophthalmology is surgery. If you're a pediatric ophthalmologist like me, you had to do an extra year in pediatric eye surgery or pediatric eyes. So we are medical doctors that diagnose, treat eye diseases, and also do surgery. I'm an eye surgeon. And optometrists are professionals that they go to school and they diagnose and treat eye disorders, but they do not do surgery. And their specialty is like, I always compare them like the family doctor and the specialty, is that they triage the patients and they do a good job with glasses, contact lenses, and now they have also prescribing optometrists, that they can prescribe some medicines like glaucoma medicines.
Exactly.
But they do not do surgery and they do not go to medical school, so the training is a lot shorter. Yeah.
So the bottom line is you're a medical doctor who also can do surgeries.
Yes.
With the area and discipline of the eye. And there's a lot going on in the eye, so I love that you brought this model along. Gabrielle, so with your nurse practitioner, there's a lot that you guys do, right? Surgery girl. I shouldn't call you girl. Surgery woman, surgery person. I'm totally going to get in trouble with so many groups for doing that. Oh my gosh, I'll just wait for those to come in.
Okay.
But explain what you do all day, every day in your role.
Okay, so my primary role, is to see, Dr. Radanovich evaluates the patient first, gives them their glasses or any of their initial diagnosis. My role is to follow up with them. So they come back in a month, in a week, 2 weeks, and make sure they're doing well, make sure they don't need any changes, make sure that everything's going well on the way they should. Dr. Radanovich will do the surgeries, and then I see them, I follow them up, and make sure that they're doing well as well.
Great. So you're kind of like first line of attack and
Yes.
last line of attack. So you're the sandwich in between, which is perfect. Dr. Radanovich,
Also, can I add something to it?
Absolutely, yes.
So the most important part of being Bell in my practice is also education. As doctors, I like to educate my patients because if not, they don't understand the treatment and the follow-up. So
Right.
then having her in my practice, she spends more time educating the patient in such a way that they can be more compliant with the treatment. Because as you know, being physicians in this town, we see a lot of patients. Because I'm the only pediatric eye surgeon in the Mexican border. So I'm very busy, I love what I do. But then I would like to complement that with education, and always did. So then she is the complement to my practice. And having her, and she's a prescribing nurse practitioner, so she prescribes medications that she can, take care of those patients that they call you and they said, oh, we didn't find this medicine, because now with COVID and the China medicines, we don't find a lot of medications. A lot of medications are out or they don't produce them at this point of time. So we had to be supplementing with different ones. And she's been a big help such a way that our patients comply with the treatment.
Nice.
And the patients love her because, she's very sweet and she's a child too, like me. So and that is very important too. And you have to communicate with parents, and you have to communicate in such a way that is a simple way. They will follow the treatment, because if you start talking in medical terms, they get lost,
Right.
Yeah. So it has to be simple, nice, kind, and then she follows up. Because
Exactly.
if we had an infection, she calls and says, and we both follow up, but she's my complement, because we both make sure that the kids are taken care of.
Correct. Great, and Gabrielle, it's true, because even before the show started, and she says, oh, it's a nervous laugh, and she was giggling and having a good time. I said, this is exactly what we need to do. We just need to be people on the show.
Yeah.
And I feel like one of my biggest jobs is to make sure that doctors are seen as people versus just the people in the white coats, which is nice white. We don't wear the white coats. Plus, the cameras don't like them. So, Gabrielle, if you could, on the get-go, so and we're talking pediatrics. So in that idea, we're talking preemies, because I do want to talk about preemies, because that's where a lot of issues happen too. Up until what, 12, 18? What is pediatric ophthalmology? What age groups would
Up
those
to
be?
18.
Till about
So
18.
preemie
Okay.
to 18.
Okay. So when people call up, and I'm going to ask you this kind of as a front line as the people who are answering the telephones, for example, at the center. What are some of the most common questions just on the get-go? It's the first time a parent calls and says, I think my child has an issue with A, B, and C. What are some of the most common questions that you get right from the front?
They can't see, they're squinting, or they're rubbing their eyes a lot, they're getting headaches, just different things. They're having trouble with reading, they're having to follow, having to read over, it's taking them long to read. Sometimes they don't want to wear their glasses because they're due for a new exam. you know.
Gotcha, right.
A lot of parents don't realize that they should be getting an exam every year, at least. Many of the kids come to us late when they should have already been wearing glasses. They come to us, they're maybe 4 or 5 years later, and
I'm about to have a coughing fit. I'm sorry, and if I do, you have to take over. So, Dr. Radenovich, my apologies. I totally am going to have a coughing fit. Some of the most common eye problems. So, you were talking about some of the symptoms people are calling in for. Some of the most common eye problems in children. Now, on the medical end, how can you describe what some of the things are going on? Like sometimes with the aging population, you've got glaucoma, and you've got other issues. And I'm going to take a drink of water and let you start answering that question. Some of the most common eye issues in children.
Well, the most common eye issues in my practice are amblyopia or lazy eye, and then strabismus of one eye that is misaligned, and I'm going to go over each of them. And another problem besides that we see very commonly here is chalazions or perillas, they call it. And I believe that probably is related a lot to our weather. And in my practice, we see many other things too, like tear duct obstructions, kids that tear, they have a black tear duct. We see premature infants because, Belle used to be my nurse practitioner at Children's. We worked together for 7 years or more. And then she moved to my practice. I do the screening of Children's Hospital for the preemie babies, and retinopathy prematurity is a blinding disorder, and we're going to talk about that too. But that is something that I do in my practice, preemie babies with eye diseases. And, cataracts in babies, that is rare, but we see them.
Oh, you
we
do?
see
Okay.
cataracts in babies, and I do the surgeries, and I do the intraocular lens implants, and we have babies seeing,
Yeah.
and we do them early. So then, but the most common ones is amblyopia and strabismus.
Okay.
Those are the bread and butter in my practice.
Okay. So let's do this. Let's just kind of chronologically go with the age of little ones. So let's talk about preemies. So there are, I remember there's a friend of mine that has a child that's, I think, 22 years old now, and she was 3 months early. And there was something about, at the time, if she was on a ventilator and extra oxygen, that somehow it would have issues with the eyes. And I'm not sure what I'm talking about. I'm hoping that you know what I'm talking about. What is that issue, and is that something that might be a little bit now different than 22 years ago?
Well, now when a preemie baby is born, the first thing you do, because the babies are born almost asphyxiated, because they're born to a new environment and under stress, the first thing you do is give them oxygen.
Right.
So the immature eye is not ready to take a lot of oxygen. So if you see here in this eyeball, we have inside the eye a film called retina, okay? The retina has blood vessels, and when the blood vessels get oxygen, the blood vessels shrink or vasoconstrict.
Okay.
And it causes hypoxia. What does it mean, hypoxia? It's low oxygen. It's like the retina gets asphyxiated too.
Okay.
So what happened is, then after the baby recovers and he's doing better, then the blood vessels dilate and bring the circulation to the eye, but the damage is already done.
I see.
And
Okay.
then, in response to this low oxygen, the blood vessels will grow abnormal. Abnormal means like spider webs, and they will break, bleed, and then form a scar tissue and detach this film and cause significant scar that will cause blindness. So what happened now, 22 years later, like now, what we do to prevent, and this disease is called retinopathy prematurity. Retinopathy prematurity is a blinding disorder that consists in neovascularization, or the formation of new blood vessels that they're bad, and they break and bleed and cause blindness. So then what we do, or the primary doctors, the neonatologists, the ones that receive the baby, is monitor the oxygen, because too much oxygen is bad. So they have to do some levels that is not too bad, it's not too high, and it's not too low. Not too low to cause brain damage, and not too high to cause blindness.
Right.
And they have their parameters. And then nutrition has improved tremendously in these babies. The babies are nourished better now with parenteral nutrition that is specialized for them, that we didn't have 22 years ago. So then the incidence of ROP probably now will be like 5%. It used to be 22 years ago, 40% of the babies will develop ROP. And from them, 30% of the little bitty ones will go blind. So now, when the disease is progressing, there is treatments. The things that we do is we do Avastin injections. It's like a little vaccine that we inject in the eye. With a microneedle, a microdose, it's only 0.25 cc's. It's tiny amount of this medicine that is like an antibody. When you have neovascularization, you have a hormone or a product called vasogenic endothelial growth factor, and that produces the neovascularization and the bad blood vessels. When you inject this vaccine, like a vaccine, that stops the growth of those blood vessels.
Interesting. Okay.
And then it stays in the eye for 20 days until the eye gets better and more mature. So those blood vessels that they are bleeding, they stop bleeding, they regress, and the disease disappears. And then the retina starts growing again, and the baby can see.
Okay.
So we have done 37 babies since 2011, 0 blindness, 0.
Nice.
So this means that this treatment prevents blindness.
Right. And this is,
And
we're
it's-
talking several months early in
Yeah.
childhood.
Okay.
So, okay.
This is
okay.
when the baby's in the NICU.
Right,
It's really
right.
less than 40 weeks, less than the time to be born.
Exactly.
When he's
Okay.
very sick, he's intubated, he's getting oxygen, he has infections, the baby's under a lot of stress, and then this disease appears, and we have to go and watch those eyes like an eagle until we can know there is a threshold when you have to treat. You don't treat everybody, you have a threshold. Because if you treat too early, it's bad. And you
Right.
treat too late, it's bad. You have a specific windows treatment, and that is the reason that having a nurse practitioner is called an ROP coordinator. She is my retinopathy prematurity nurse coordinator. She watches these babies, and she makes sure every Monday I was in the hospital, I was checking those babies. We have a list, and every 2 weeks we're following those babies until the danger is gone and the eyes are mature. And if they need treatment, we have to do it right away.
Right.
And the interesting part is this medication only costs $40 each syringe. It's $80 plus the transport, because they have to be made in a special pharmacy in Houston. We call it compound pharmacies under sterile conditions. It's like a $200 treatment, because we have to pay the UPS, the shipping the same day, and to prevent blindness. We used to do lasers before.
Oh, my goodness.
10 years ago, the lasers will
On
burn
preemies, on
preemies
babies in the
eyes.
NICU. Okay.
But we used to burn the retina.
Oh, goodness.
Burn, like to stop the bleeding. And then burning the retina will take away 30% or 40% of the peripheral vision.
Right.
And then, but that was the best we had. We
Yeah.
had to intubate the baby, because the baby wouldn't take 1,000 shots
Goodness.
in the eye.
Wow.
So then, now that we do Avastin, that is an Avastin injection, it's changed the
The whole
the-
trajectory of how things are
Yes,
going. Yeah.
yes.
And that's
And-
great. And this is
and it's
so,
something to share, because not many doctors do that.
yeah.
Still, doctors are working in prehistoric ages, And then I say, which medication, which laser will cure blindness? No, because you're causing blindness with laser.
Right.
Because you're burning 40% of the retina, that causes scar tissue and peripheral vision loss. So you can see centrally, but your peripheral is gone.
Right.
So then I think now the new modern era is to go towards Avastin. And it's the same thing that they use now. The same drug is used for the elderly for age-related macular degeneration.
Oh, good.
You know, and
So there's a
then-
lot of been that's been discovered the
yeah,
last
but
couple of years in this
in the
area.
elderly, the dose is bigger.
Right.
The needles are bigger. I'm trying.
Needles in the eye, but I know it corrects a lot of things. I want to move on to some of the most common, again, when you're looking at young children, and if it's able to be corrected when they're young, this is great. And one of them, again, is the amblyopia, which is the weak eye. Is that what some people refer to also as lazy eye? Would that be correct? And so is that a muscle issue that's happening, an optic nerve issue that's happening, or what is happening there physiologically in the eye?
Well, amblyopia is an abnormal development of vision
Okay.
in one or both eyes since early childhood. And normally the eye transmits the images from the eye to the brain. And the optic nerve is a cord that connects with the brain. And in the back of the brain, we have the vision center. It's like the images are captured in the eye and downloaded through the nerve towards the vision center. But if the images are blurry, then the vision center in the back of the brain does not develop. It's smaller, it's like a muscle. So then it's not only that your eye cannot see, the brain doesn't see. So then it becomes a more complex issue. But if you detect this one very early, early means less than 3 years of age, you can correct amblyopia and you can prevent loss of vision, because amblyopia is loss of vision, is decreased vision.
And so how do you correct that? What would the procedures be to correct that?
Well, there is different kinds of amblyopia. One is called refractive amblyopia. That means that the kid needed glasses since very early age, and it was missed because we didn't have the technology to detect that. The pediatricians don't have the technology to know if you are nearsighted in one eye and farsighted in the other. So refractive errors as myopia, astigmatism, and hyperopia that it starts very early in life is the most common cause of amblyopia, decreased vision. So now, how can you prevent it? Pediatricians are doing a lot of photo screening. I don't know if you have kids that they go to the pediatrician's office and they take a picture of their eyes. And they said, oh, you may have amblyopia. You have to go to the specialist. So then we need to screen the kids early. That means that the pediatricians do a very good job screening the eyes, but the parents need to request the pediatricians to have their vision checked very early. Very early means less than 3 years.
Right, and so that brings me to a whole nother point, and I'm gonna switch over to Gabrielle for a second. I know we talked in the beginning of what the symptoms are. What are you looking out for? So let's say with a child that's less than a year old, you don't know that they can't see well. They don't know that they can't see well. What is it that, it's easy to just say, you know, once they start looking at things that they're having a hard time, but prior to the age of 1, what might you be able to see in a child so that you would bring that child to be screened at a doctor's office? Or would a pediatrician pick that up? I don't know.
One of the big ones is they're not tracking.
They're not tracking.
Yes,
So
and
like
that
looking at a
happens-
ball or looking at
Yes,
your
so
fingers.
they're not following their parents, or they're showing the light. They're not following the light. That's a big, big one. Another one, maybe for a little bit older, maybe they're not meeting milestones. They're not crawling, or they're not starting to walk when they should start walking. That's another
And that
big
could be
one.
an optical
Vision,
issue.
yes.
Okay.
Or they're going to physical therapy, occupational therapy, and they're doing the therapy, but it's not getting better.
Okay.
And then they recommend getting their vision checked.
Okay. So then how does, so a big part of what you do is diagnosing what's happening and what's going on. And I don't know who to throw that to. I wanted to give you some time. For diagnosing, so now they come to you, there's something wrong, they need to figure out, so how is it that you diagnose certain issues? And let's keep it from 1 and under, because they can't tell you what's going on. And again, that's where the development is still at a minimal.
A lot of that is doctor.
Yeah, okay, you want to take that one? So just diagnosing, how do you see and find out what the issues are with the eye?
Well, when we have a baby in our office, so we have to check how they track. We have lights, we have toys, and I use a lot of lighted toys, like colorful toys with lights that spin, such a way that we can see, cover one eye, see how they track, cover the other eye, see how they track, check their pupils with a flashlight to see if the pupils react, because if you have good vision, your pupils will react.
Okay.
And then we have also instruments that will take a picture of the eye and give you the refractive error. If the baby, at 6 months, we can detect if they're nearsighted, farsighted, astigmatism. And
At 6 months?
Yeah, and
Okay.
detect amblyopia.
Okay.
Earlier than that, 2 months.
Okay.
And then we have to dilate the eye with special drops because we need to look inside.
Right.
Because they can have optic nerve problems, optic nerve undeveloped. They can have detachments of the retina. They can have also tumors like retinoblastoma that is detectable by us sometimes early. And also they can have multiple abnormalities, or they can be everything normal, and we're happy that everything inside the eye is normal. That is for babies, that is for 6-month-old, that they don't talk. There is also, when you're a pediatric ophthalmologist like me, we have a device called retinoscope, and without the baby talking, I can look at the red reflex of the eye, because we have a red reflex with a light, and you can check with lenses and motion and neutralize motion and know if they are farsighted, nearsighted, astigmatism, and know exactly the power.
Okay.
And we can give glasses very early to prevent amblyopia.
And this is not saying, for example, I'm a grown-up, so it's like, is it blurry? Better or worse? Better or worse? And so I really do. I think to myself, how does a 1-year-old have eyeglasses? You know, to me, I just think, how is that diagnosed? That's fascinating to me.
With that
That you
procedure,
can see that.
yeah, with that procedure called retinoscopy.
Okay.
And we are trained on that.
Right.
Now, let me tell you, it's I learned it from the optometric school. I trained in Houston, but we used to rotate in a clinic, St. Joseph's, where the optometrists had their rotation. So then one of the optometric professors taught me, because we're trained to do eye surgery. Yeah, we do glasses, but they do glasses very well.
Right.
So then I learned from them, and it's so useful for me. I can do that in 2 minutes. People say, "How can you know that?" You
It's
know?
your area of expertise.
Yeah.
No, that's
yeah,
fantastic.
yeah.
Excellent. So let's now go to strabismus.
Yeah.
The
But,
cross-
but let me tell you
Yes.
about amblyopia a little more, because
Okay.
it's not only just the diagnosis. We diagnose amblyopia. Okay, you said one eye is seen more blurry than the other one.
Right.
Then, oh, this kid has astigmatism, let's put him in glasses, you know?
Right.
And then that doesn't stop the treatment. We have to patch.
Okay.
We patch the good eye to make the lazy eye work harder.
I see.
And then now we are we're down to 2 hours a day of patching, because being consistent and patching 2 hours a day, the good eye, the lazy eye will improve. But
So it's a workout for the eye
Yes,
at the end of the day.
And I tell the parents, it's like working out a muscle, because if you don't do that, the brain vision won't develop. And I said, and the kids, when they're young, let me tell you, you patch 1 month and things are good, are resolved.
Really?
But you have to have their glasses.
Interesting.
And then in kids that they are 6 years of, we had to patch 1 year, 2
Yeah.
years, then we had to deal with compliance. And then in kids that above 14, then the treatment is done.
I see.
We can't do more patching. We used to say we give up at 10, but because at 10 the vision development in the brain is completely done. But now we do the patching, or we put contact lenses that blur the eye up to 14 years of age. So
Okay.
then we can still improve the amblyopia. So then the diagnosis, the treatment, if they need glasses, is glasses, and then patching.
And this would not be something that would work in someone who is finished with growing. Would that be correct? So say somebody tries to do the patching and they're 25 years old, let's just say, and would that in no way, shape, or form work on someone who's already finished developing physiologically in their body and in their brain?
Well, we used to think that it doesn't.
Okay.
But I took trauma call at UMC when I just came for 10 years. And we had patients that sometimes they had a lazy eye that they couldn't see. What happened with the trauma, they lost the good eye. And
okay.
then a year later, the eye that was seen very poorly, now it starts seeing again.
Wow.
And I said, well, still the brain will show some improvement. I don't know, the brain is amazing. Still the brain will show some improvement in vision in you're an adult. But we don't do it that often, because who is going to patch being an adult? You're busy with your schedule.
Yeah.
And many people say, no, it's done, you know? But some people still try to do that. But I think the success is much less.
Yeah.
So then
Yeah.
sometimes it creates frustration in older patients. But I've seen it in trauma. You know,
Yeah.
when you lose your good eye, the lazy eye get better, and you are
Exactly.
already 30 years old, 35. So then that means that there is.
That's
is
when you
still
realize that the human body is really an amazing organ altogether, so to
Yes.
speak.
Yes.
So let's move on now to crossed eyes, because again, that's something that I feel like since the last time we had an ophthalmology show for pediatrics, there have been a lot of things that have come to light regarding the surgeries to help that out, to help straighten out the muscles of an eye. And again, that's fascinating to me. So diagnosis, I think, would just simply be easier because you can actually see, as you were saying, that the tracking is completely off. But then going into surgery, what physiologically are you doing in that case to help the eye either straighten or the muscles, or in that, it's going to be fascinating to listen to this explanation.
Well, this is just a model eye, okay?
Yeah.
And these red things that you see around their muscles, the muscles have been resected here. So it's like they are cords
Okay.
that they move the eye. One moves the eye in, the other one moves the eye out. There is muscles that move the eye up. There's muscles that move the eye down. So then what you do is through microsurgery, you go through the front of the eye, and then you make like a 2-3 millimeter incision. And then you have to move if the eye is tight, like just talk about strabismus. Strabismus is an eye that is misaligned. So then it can be in, we call it, turn
Right.
in or crossed in,
Right.
and it's called esotropia. It could be out, and it's called exotropia. Then if you have an eye that is in, this muscle is very tight. And then you have to move the muscle back to untight. As I could tell the parents, we're going to loosen that muscle such a way that it's not pulling. It's like a force, like
Right,
a cord
yeah.
that is tight.
And then you just kind of have to know what that perfect tension would be at that time, right? I mean,
Well,
that
we-
seems very
we
complicated.
do measurements.
Okay.
We measure the angle of deviation with prisms. We know if they are deviated 30, 40.
I see.
The larger the angle, the more urgent the surgery.
Right.
Because if you cross a little bit, then you have to do your patching, your glasses. But if you are crossed like this, poor kid, you have to align them.
Yeah.
And patching glasses is not going to help. You're
Right,
not going
right.
to leave that kid there. And then just aligning them will improve their peripheral vision, will get the visual input from the eye to the brain, and the vision will improve. So then success, I always tell the parents, they always ask me, how much is the success of the surgery? I said 80% is successful. 20% are chances that we may have to do it again 6 months later or maybe 20 years later. But who is going to offer you 80% success in a surgery
Right.
that will return a lot of your vision? But you do the procedures early. Like if a child crosses before the year of age, you have to do the surgery before the year of age. The earliest I've done is 4 months of age. If a child is being crossing until she was 6, and nobody, because in town there is a lot of, what I call it grandma tells, that they said, oh no, that is going to improve. That is not going to get worse. And don't worry, your aunt had that and she got better. And then we get kids that they are 10 years old with an eye that is crossed when the vision is lost. But let me tell you, you fix them, still the vision improves, the depth perception improves. And let me tell you what is the most important part is the quality of life of that child.
Right,
He can do
exactly.
sports, he can do better in school, his reading scores, he becomes more confident. I think that is what is our job, to improve
Absolutely.
their function. It's not just, we do the surgery.
No, yeah.
It's like we do the surgery to improve the vision and to improve the function and to improve the quality of that kid such a way that that kid can go to college and can do anything he wants.
Exactly.
Because he has good vision.
So Gabrielle, I'm going to take this on to you and the education now. So let's say that this procedure has occurred,
Okay.
and now the eyes are tracking better, the muscles are better, but then I'm assuming that there are some exercises and education to go further into the next week, the next month, the next several months, even into years. What are some of the things that you are training the patients or the patient's parents really about?
I think we should start like even before surgery. We
Okay,
have to,
actually,
I like
that's a
to
great
talk
idea.
to them
Yes,
about
yes,
the
absolutely.
surgery itself.
Okay.
Once parents hear surgery, it's like they shut down.
They freak out, yeah. They
So
shut down.
They do. It's like they don't listen anymore.
Yeah.
So I like to talk to them even before the surgery, like what to expect afterwards. The biggest concern is that their eyes are red.
Oh.
And if they stay like that for a couple weeks, you know, so
Yeah.
I like to let
and
them
that's
know.
natural.
That's normal.
Okay, that's
Mhm.
normal.
I like to let them know what the treatment plan is afterwards, you know, what medication they're going to be using and what to expect. Then they have their surgery, they come back to me a week after, and then we're going over everything again because they've forgotten, you know, they're doing the medication incorrectly, you know.
Oh,
So I
yeah.
like to ask them a lot of questions.
And so what do some of the medications, are they eye drops as well as oral medications? Is it a myriad of things?
So
or?
the typical medication is an ointment,
Okay.
an antibiotic with a steroid. Unless they're older, then we'll do a combination of drops and an ointment.
Okay.
But a lot of parents, like I said, they don't pay attention. Not that they don't pay attention, I think they get nervous.
It's overwhelming.
Yes.
You know, it's overwhelming when you have a very little one going through
Yes.
this. I respect that.
The only thing they think about is the anesthesia,
Oh,
you know?
yeah.
So they get nervous, so I talk to them about that as well. So then they come to me a week after and we talk about the education, about the medication, how to apply it correctly. That's a big, big one because a lot of parents don't know how to apply ointment.
And so how would you apply it?
So they're kids, a lot of kids will fight you.
Oh, I'm sure.
So we do have to teach them how to apply it, you know, above the lashes, you know, going under the lashes and just putting a good amount of medication. A lot of them want to save the tube.
Oh,
And so we tell them, you know, you need to squeeze it out.
right. Yeah.
And of course, if the child is old enough, they'll open their eye and then you can apply it
Okay.
into the eye.
So the important thing is to get it inside the eye.
Yes.
And of course, someone that's very small, it's going to be incredibly uncomfortable. And that is an educational process, right? You have to
Yes.
try to get that going there too.
And another difficult thing for them is these kids have to stay indoors for 2 weeks after their surgery.
So no sunlight.
So
Is that why?
no outdoors, no playing outside. You don't want them around dirt. We don't want them around animals. So that's been like the
Oh.
most challenging for them, poor kids.
But
Especially,
COVID time has helped.
yes.
Yes. Now you can blame it on that.
Yeah.
Right.
The parents says, oh, this surgery. I said, yeah, but 2 weeks he has to be indoors, no swimming.
No swimming.
play."
Yeah.
That's
Oh,
the big
okay,
one.
that's good because you know we can't go outdoors anyway, and it's
Yeah.
not good. So
Yeah.
that has been not that a main issue now. No, it's better.
It's helping us.
It's helping us. That is good.
Well, we have a question here from the audience, and again, this is new, and I didn't tell you guys before the show. I'm not just, playing on my computer. We're getting the questions in through texting on the computer. And one of the questions here from the audience is, are there any recommendations for preventative care for eyes that are diseased? And maybe we can talk about diseases in children. I know that we were talking about the different problems here, but are there any preventative issues with that?
Well, just amblyopia. How can you prevent amblyopia? You have to go to your screenings with your pediatricians, and you have to go and the first physical, the follow-ups, because pediatricians are the primary doctors that refer patients to us.
Right.
And then if things are detected early, you are going to treat them early, and then
Exactly.
they're going to have great outcomes. Parents need to watch what are signs of amblyopia or lazy eye.
Okay.
An eye that is crossing, an eye that is squinting. They go outdoors and they squint their eyes. They now with electronics, they put things very close, the front
Right.
very close to the eyes. They tilt their head to see. Oh, mom, I have a headache after
Right.
school or when they read. And some other babies, you just see a cloud in the eye for cataracts, because cataracts also cause amblyopia. If you see any unusual things in the eyes, and mommies are very perspicacious. They really
Yeah.
observe, because we get the moms to detect cataracts. They said, I see a film, kind of silverish in the eye, and that was unusual. Or in the camera, you take pictures, have you seen that? And then one eye comes out white, and the other eye comes out
Exactly.
red.
Yeah, that's an
Then
issue.
you have to go to your pediatrician and have you referred to a specialist like me.
Right.
Because those things are preventative. If you know what to look for, and then you look for assistance or help with your primary care doctor, then you can be referred to us.
Right.
Or you can just call us too, but most of our patients have to be referred by the PCP
Okay.
because of their insurances. It's mostly, it's not because of me. I would like everybody to come directly to me, but the system has made it a little more complicated. You have to go to your pediatrician, and the pediatrician has to refer the patient to a specialist. Yeah.
So this is not a question, but I love it when this happens. Somebody called in and he gave his name, and he just wanted to say, Joshua wanted to say thank you to Dr. Radenovich for operating on his family members. So I don't know who Joshua is. I know we can't give out law, but that's a beautiful thing, because I know you've been around for, my gosh, at least 22 years, because this person I was talking about, you were that individual's doctor as well. So that's such a beautiful thing.
Thank you.
Oh,
Thank
it's
you.
nice to hear,
I'm
right?
glad to help.
Yeah.
You know, I'm glad to help, and it's very good to feel appreciated.
Yeah, agreed,
know,
agreed. And you're
because-
really, like you
yes.
said, making a difference
Yes.
in the lives of young ones. Talk about, again, this is newborns again, but tear duct issues. That sometimes there are clogging of the tear ducts or obstructions of the tear ducts when either newborns or just when they're young in general. How can you tell that there's a clogging of the tear duct? There's nothing coming out? I guess that would be a question if I was a mom. How would I know that a tear duct is actually clogged?
Because your baby will have constant tearing and discharge,
Okay.
and since birth.
Since birth.
Since birth.
Okay. Okay.
And you know, the treatment normally, 6% of the newborns have a clogged tear duct. 6%. That is not. That's common.
Yeah, that's pretty
And
big.
my baby had one. So
Uh-huh.
what do? You have to massage the tear duct, because the tear duct is in this corner. It's not in the eye. It's in this corner. The tear duct drains the tears from the eyes towards the nose. So then you have to do massages, front massages in this corner every time you feed the baby.
Every time
know?
you feed the baby.
Every time
Okay.
you feed the baby for
Okay.
1 or 2 minutes, you know. And then if he has green discharge, you have to ask the pediatrician for some eye drops and antibiotic just to complement. Most of the time, by 4 months of age, the tear duct will open up on its own. And it can open up until the year of age, but it's unlikely, okay? If I said it hasn't opened by 6 months, let's do something. We do open
Oh,
the
it
tear
could be
duct.
that long.
Oh, yeah.
Oh, my goodness, okay.
But we do early procedures in the office. We flash the tear ducts. I call the parents, the fathers understand this better, because I tell them it's like the plumbing that was clogged. What do? You flush it with water, no? And then sometimes you had to put a little snare, but to get to that, you had to put them under anesthesia sometimes. So then what we do is we do a probing procedure. We call it an irrigation of the tear duct early, by 4 months of age. Especially in the mothers working mothers, or mothers that they're always worried because it's always pussy, it's always green.
Right, right.
Parents are concerned. You know,
Oh, it's
when you
disturbing,
see your
yeah.
baby's disturbing, and they say, we can fix it. It takes a minute in the office with a little drop of anesthesia. We hold them down. It's drops, not anesthesia, drops that numb the area.
Okay.
And then it takes me 30 seconds to a minute.
Oh,
and
my
it's
goodness.
done.
Okay.
The success rate, 85% to 90%. It can come back again, and we have to do it again.
Okay.
But what happens if you wait until they're 6 months? Then if we have to do it, we have to put them under anesthesia in the surgical center.
Right.
And then we don't want to do that if we don't have to, but
Right.
we do that too, because some kids come with a bunch of infections, and you have to resolve the infection.
Okay.
So then the procedure is very successful. I would say
Okay.
99% successful. But parents can do the massages early,
Mm-hmm.
and then also help the tear duct to open to prevent to have the procedure, you know? Yeah.
Another question here from the audience, and this is vague, but I'd like to touch base on it, because there are some conditions that children have that worsen within time and their vision disappears. I do this as a volunteer. My real job is working with the El Paso Community Foundation, and so since Lighthouse for the Blind has been gone for a while, we're looking at doing another low vision and blind type of a program. But the question here is, are there any cures for children, and I don't remember the condition, that know that the doctors already know the condition is that they're going to go blind? You could probably tell me right off the bat which conditions those are, and if there are any steps to take before vision loss or to slow down vision loss if that is what you've been diagnosed with. I know I'm kind of going around the question because I don't remember exactly the name of the condition. That's a question here from the audience.
Well, things that they don't have cure at
And
this
and it's
point,
genetic, let's say.
and
yeah.
it's genetic,
Yes.
is retina degenerations or retinal dystrophies. That means the retina,
Okay.
this film will start to degenerate, and
Okay.
it will start to
Point it to that camera
get
if you don't mind.
disease
Okay.
of the retina. And we call it retinal dystrophies, retinal degenerations. One of the one that has treatment but is not perfect is called Leber's congenital amaurosis, Leber's.
Okay.
And livers now have a gene detected, okay? But if you have that gene, you can get the treatment genetically treated, but the percentage of patients that they have livers with that gene is very, very rare. But that
Yeah.
is what we're doing, but that is brand new. It's the company that is promoting the treatment, because it's all genetics. The company is doing it now for free. So then, if you have children that have livers, come to the office, we have the test. It's a saliva test.
right.
And then we send it to the company, and if you have the PX gene for livers, there is a gene for livers that has the treatment, then the company will provide that for you.
Ah.
We had, it's very rare livers, congenital amaurosis, it's a retinal degeneration. We had 3 patients that we tested, but they didn't have the luck that they had the gene that, that fit the treatment. But
Gotcha.
I think those are things that they don't have a cure. They will progressively get worse. The only thing you have to do is get low vision aids. Some people have been researching stem cell therapy.
Right, yes.
And I'm not an expert in that. So then the retina specialists are experts, but there is no cure at this point. But there is a lot of research going on. I had patients with retinitis pigmentosa too, and that is genetics. Genetics runs in families. When I find one child, I want to see all of them.
Right.
Because we want to make sure that no other children is affected. And then we have to see the family tree.
Yes.
And then, because we know that one day we may have a cure for these things, because genetics is advancing so fast.
It is amazing, and I talk to these students, so before the show and after the show often, that if there is something you want to go into, genetics it's fascinating to me, all the new things that are happening in the world of genetics.
Yes.
On that note, when you're looking at the family tree, is it something that both parents have to carry a gene for certain issues, or can it be just one parent? I know with
Well-
oncology, often we talk about the combination of the 2 parents and then going in from there.
Well, when you have recessive genes, you need both parents for the disease to manifest.
Okay.
But dominant genes, you may not need both parents. Like cataracts in babies have a dominant gene. That means the parents have cataracts and the babies have cataracts. So then it's 50% dominant.
Right,
So then
okay.
when we see a baby with bilateral cataracts, we look for the family history. And then different disorders, because cataracts also infections,
Right.
especially here toxoplasmosis, the cat parasite. We do herpes.
The cat
syphilis.
parasite.
Yeah.
I'm not aware of that.
Toxoplasmosis. The cat has a parasite, and the parasite has, if you ingest those eggs,
Ew.
you can
Okay.
get infection towards your eye. The parasite lives in your eye and eats part of your retina, and then you can go
Yuck.
blind. Yeah. And it
I
can
have
cause
not heard of that.
Yeah.
I don't have a cat.
It's
Maybe
called-
that's why.
It's called toxoplasmosis.
Yeah.
For that reason, it's nice to have your cat look.
Yes, take your cat
Take
to
it
the vet.
Yeah.
Goodness gracious,
Take
yes.
and especially when you have babies or little kids, because we see them in children, because those are the ones that play with the litter and they're with the cat.
Yeah.
We parents know, because you're
Right.
cleaning that with gloves and things, but
Yeah.
it's the little ones, yeah.
Good to know. Gabrielle, I'm going to come to you with some of the non-surgical type stuff, and it's like pink eye. Who in the world has not ever had pink eye, right? Or stigmatism? How does one get pink eye? All I know is it's very contagious. Somebody can get sent home from school with pink eye, and you're not allowed to go back to school. You're not supposed to touch anything or touch anyone. Talk to us about what pink eye is, how it's spread, and without getting treated, what can happen? Because I know it's a pretty big deal if you don't get it treated.
So you can have viral pink eye, or you can have bacterial. Bacterial is the worst one, I think. It's the kids that are not washing their hands. They're touching their eyes. They're touching everything. It's a windy day, and that's when everybody wants to go for their
right,
eyes, and
right.
they're spreading it like that. They come in with their red eyes all gooey, or they're waking up in the morning and their eyes are stuck together.
I've had
Yeah.
that. I hate to say it, and it's gross and it's uncomfortable. So to diagnose, and every now and again you'll have, and I guess that's astigmatism, when you have just a red bump on your eye and it just doesn't go away. What is that caused by? And I know there's different causes, but in general, how would you treat that?
And that's what we were talking about earlier with the chalazions.
Yeah.
This weather in El Paso.
Yeah.
It's not good for it.
You don't like
Like-
our beautiful winds
well,
that
I
blow
know.
all kinds of stuff everywhere?
I love
There are
it.
very few complaints about El Paso's weather.
I know.
But that is one of them for sure. But maybe we can talk about that. And I do want to come back to how to how to treat pink eye, and we'll go from there. But stigmatism, not stigmatism, that's the wrong word. What's the word I'm looking for? It's not pink eye, but when you have a bump on your eye.
The chalazion or a sty.
A sty, thank you, that's what
Yeah.
I'm looking for. I'm looking for a sty. So a sty, how does one get a sty? Is that where, I don't know, it just seems like a small infection starts occurring in the eye, or?
Do you have the, it's like, what is this one? That one.
They're so small, honestly, I can't see. Let's see if we can go to slide 7, and it would be the part where you actually see the young
The
boy
bump.
with the bump on his eye. So Gracie, and this is where our superstars in the back will pull up that slide. So again, it's slide number 7, where it's a style, and we would go to the page. It's probably the 3rd page in that handout, and it would be the photograph of the little boy that has a bump on his eye, and they're looking at pulling that up. But in the meantime, great, and if we can go to the photo, there's probably the screen after that.
Yeah, the screen after that.
And so as she's pulling it up, what is it
Okay.
that we can explain in the meantime?
Let me tell you the definition of, you have to differentiate
There
chalazium
we
and
go.
style. Chalazium, no, there's a cross eye.
Yeah, that's
That's
a
okay,
different
let me
one.
explain that.
Okay.
Chalazium is a bump.
That one, yeah.
Yeah, it's a bump on the eyelid caused by a clogged oil gland.
Okay.
Each eyelash has oil glands, and we call it the meibomian glands. And when they get clogged, they are like tubes that they go up the eyelid, and then you see those cysts. And the treatment for that is warm compresses, okay?
Uh-huh.
And you know, grandmas used to say chamomile tea. Chamomile tea has anti-inflammatory properties, and that is what I tell them. Do some warm compresses with chamomile tea, 5 minutes each time, 3 to 4 times a day. A little ointment, antibiotic with anti-inflammatory. Has a little combination of steroids with because that is an inflammation. And then we do, if we treat it acutely, we do it for 2 weeks. And then if it keeps getting worse, we have to incise and drain because it's like an abscess.
Right.
And then, but the sty now
Uh-huh.
is like a little pustule. You see it at the edge of the eyelash, and it's a whitehead. It's like having a whitehead
Oh, goodness.
here.
Okay,
And that
gotcha.
is a sty, and that normally pops with warm compresses and the medicine. Those don't need to be incised and drained.
Gotcha.
But sometimes if you don't incise and drain those bumps, they can get and form cellulitis. That means the infection goes, it spreads around the eye, it can spread around the orbit. Every time, this time of the year when we have the winds,
Uh-huh.
sometimes we have to put patients in the hospital to get IV antibiotics.
Oh, my
So if I
goodness.
see a
Okay.
bump like that and it's
Yeah.
been there for a month, I have to drain it.
Oh,
There is
goodness,
no
yes.
way that is going to, how is going to drain if you don't see the head, no?
Right,
Because
right.
normally we put the warm packs to have the head and then drain.
Mm-hmm.
And many times it happens. And sometimes many times don't happen. It's
Right.
very common. We see a lot of this in this area.
Huh.
And I think 50% of them or more are related to allergies. So
Okay.
when I see them multiple and when I see them recurrent, that means it keeps coming back, I tell the parents, you need to go to the allergist to have yourself tested because weeds, pollen, cat, dander,
Yeah.
those allergies will contribute to inflammation of the eyelids because the kids are grabbing stuff, they go to the park and then they rub their eyes.
Right.
And some of them do not have allergies, but they have, we call it atopic. That means there is no history of allergies, but they have asthma, they have dry skin. So those kids have predisposition to have these too.
Okay.
So then my advice to the parents as a prevention, if you take your kids to the park and they come home, please, they have to take a shower, but just get a bottle with water to the park and wash their eyes when they finish sweating in the park. Just wash their eyes. They don't need soap and water, just the water from a bottle that you don't have to buy the water. You can fill it with your, with a bottle that you had at home and from the sink. Because I don't know, but when I go to the park and sometimes I walk or I run, I get my eyes pretty itchy.
Right.
And if you get into that grass,
Yeah.
because I had to sometimes tire, and you have a lot of something that itches your eyes, your body. So I think that would be as a prevention. Always wash your kids' hands, because if they touch something dirty and they will rub their eyes, they may cause this one too.
Right.
So then it's just
It's another
prevention.
good reason to have kids wash their face,
Yeah.
including their eyes.
And wash their eyes. And then,
Yeah.
like my mom used to say, do not touch your eyes with your dirty hands.
That's why you're an eye doctor. I'm certain of it. We're kind of at that point where we're starting to wind down the show. So, Gabriela, I want you to just in the back of your head start thinking about some things that maybe we haven't talked about yet this evening, or things that we have kind of touched base on, but we haven't really dived into what that is. And again, some of the most common questions are the pink eye question. So you had explained earlier that there is bacteria and there is also virus. So the viral is not something that you can do an antibiotic for.
No.
And that's something we want to talk a lot about on the show, because I think sometimes parents are like, anything that's wrong, give them an antibiotic. So if you could take that as to why it's not always appropriate to give an antibiotic and the difference between, you know, the treatments of a bacterial infection versus a viral infection.
Okay. So the viral conjunctivitis, I mean, it's not a bacteria that's causing the infection, so we wouldn't give the antibiotic. It would be more comfort measures.
Okay.
Maybe applying a cold compress on their eyes, even giving Tylenol, but making sure they're not touching their eyes.
And how would you know that it's viral versus
So
bacterial? Is there a certain test that you?
If they're having all the green discharge, the yellow discharge, they're waking up with their eyes stuck together.
This is where we
typically
should have had
bacterial.
really gross pictures. This could have been a great show to have really gross pictures. That's like what I live for on this show. So next time you come on, you got to bring some gross pictures on, because we've all seen it, right?
Yes.
Yeah.
Okay, so
Yes.
that would be viral. You said, right?
The viral would be, the bacterial would be the one with all their
All the
eyes
icky
stuck
stuff.
together.
Okay,
It's
so
all
that's the stuff you
green
take
and
the
nasty.
antibiotic for.
Yes.
And what kind of an antibiotic would that be?
We typically use Vigamox or moxifloxacin. That would
Okay.
be our go-to.
Okay.
But still the cold compresses as well, just for comfort.
Okay.
And of course, washing their pillowcases, don't share any towels, make sure they're washing their hands.
Exactly.
The hand washing is the big one.
You know, hand washing all around. If
Yes.
anything, COVID has taught us. And Dr. Donovich, you were so cute. You're like, really? We have to wear a mask on TV? It's like, yeah, if we're 10 feet apart, then we don't have to wear masks. But we're like right at the cusp of 5 feet, so we're going to keep with the social distancing. But in general, washing hands, because we now look at it not as a joke, but something like the first thing that they told us during COVID, wash your hands, don't touch your face. And that's exactly what we're talking specifically about tonight. You're talking about the cat litter, et cetera. Keep your hands clean and try to train your kids from keeping their hands from their face. And that goes with so many things. I would love for you to talk about something, or again, stress something that we haven't talked about yet this evening. We got about 4 minutes left before we close up the program. Is there anything that you wanted to say that we didn't touch base on yet?
Well, just to teach the parents what to do with the strabismus.
Uh-huh.
Okay? The babies up till 4 months of age, they can cross their eyes. Okay, the development of the vision. When a baby is born, they see lights. At 2 months of age, they fix in the mother's face. At 4 months of age, they're already tracking and seeing everything. So we have babies that the parents bring us when there is a month or so, because the babies looks like they're crossing. But they're not crossing yet because their eyes are immature. They're learning how to focus. But if your baby crosses after 4 months of age, they need to be referred immediately because it's not normal. Babies with wiggling eyes, we had a baby this week that the baby at 2 months had wiggling eyes and a cross eye, but the crossing was like severe, like the eye was like this and wiggling. He couldn't track and he couldn't see. This is not to scare you guys, but brain tumors can cause this. The baby had a brain tumor. So then strabismus can be, an acute onset of strabismus can be caused by a brain tumor. And we've saved, let me tell you, I saved a few kids in my 22 years, and I feel really proud of it because they appreciate that what we did. Because when we find this, it's normally early. You know, like the baby that we just diagnosed with this brain tumor is at 2 months of age, and the tumor is 1.3 centimeters in size.
Wow.
And the surgery will be not as hard. Dr. Jimenez says that it's not going to be as when you have a big tumor and invaded all the brain. So this kid, we are going to save his vision.
Right.
But he already had some damage. So then I think moms, for you, the baby that crosses after 4 months of age, please bring them. Any child that crosses is not normal because it can be amblyopia or lazy eye because they need just glasses and that eye doesn't see. And we can treat strabismus with patching and glasses. It can be prematurity. 30% of the premature babies can cross. It can be babies with cerebral palsy. A lot of special need kids come to my office, and I love them because a lot of them need some visual aids to perform in school. Then the other thing that I would recommend is strabismus. The treatment is if they need glasses, patching, and then surgery, okay? Because people says, oh no, they told me it's too late to do surgery. No, if your eyes cross, there is never too late to do the surgery. But there is the steps before that. We need to know why it crossed. We need to treat that first. We need to treat vision. Vision rehab is the first thing that we do, and then we'll go into surgery at later step.
Okay.
The other thing now, before the show finishes, is screen time. With COVID time now, the kids are in the screen for a long period of times. The American Academy of Pediatrics has recommended under 18 months, please don't keep your kids in the screen. The babies shouldn't be in the screen because we have the blue light. We have things that they can be damaged. And also, blue filters can be good for the kids, and check their vision.
And that, I think that's great advice for everybody. I want to tell everybody once again, the telephone number to call your office, 577-9339, and www.childrenseyecenter.com. If you want to watch a show over, once again, you can go to the PBS El Paso website, pbselpaso.org, and then also epcms.com. Thank you so much for watching this evening. Again, wear your masks in public. Even if you're 6 feet apart, 10 feet apart, 12 feet apart, it's very, very important in this time. I'm Catherine Berg, and you've been watching the El Paso Physician. Sorry.